Hello everyone, my name is Zoha Tamkeen and I'm a PharmD second year student at Geetanjali College of Pharmacy. Today's topic of discussion is Tourette's syndrome. Now, what exactly is Tourette's syndrome? Well, Tourette's syndrome, often simply called as Tourette's, is a neurological disorder that typically begins in childhood. This is named after the French physician Georges Gilles de la Tourette, who first described the condition in the 19th century. This disorder, Tourette syndrome, is characterized by repetitive involuntary movements and vocalization known as tics. Now, this brings us to the question of what exactly are tics? Well, tics are repetitive movements or unwanted sounds that can't be easily controlled, as seen. Repeated blinking of eyes, shrugging of shoulders, blurting out unusual sounds, or offensive words are some examples of tics. This brings us to the question that are there any types of tics? Well, the types of tics are motor tics, vocal phonic tics, which also have subtypes such as simple motor tics and complex motor tics. Simple motor tics are quick, brief, repetitive movements involving just a few muscles like eye blinking, head jerking, and shoulder shrugging. The complex motor tics include coordinated, purposeful looking movements, which involve multiple muscle groups like touching of objects, hopping, twirling around. Coming on to the vocal or phonic tics, these are also simple and complex. The simple vocal tics are short, meaningless sounds made through the mouth, nose, or throat. Examples are grunting, coughing, and throat clearing. Whereas the complex vocal tics are words or elaborate phrases. Sometimes it can be inappropriate. The terms for these are coprolalia, echolalia, and palilalia, repeating words, swearing, and mimicking speech. And this brings us to the question that what exactly causes Tourette's syndrome? Well, the exact cause of Tourette's isn't fully understood, but there are several etiological factors like genetic, neurobiological, environmental, autoimmune, and psychosocial factors. First, let's see the genetic factors. Tourette's has a strong genetic component, though it doesn't follow a simple inheritance pattern. Most researchers believe that it is polygenic, which means that it has involvement of multiple genes. And key genes linked to Tourette's are SLITRK1, which is SLIT and NTRK like family member 1. It is involved in the neuron development and synaptic functioning in the brain. If a rare mutation or variation occurs, this leads to Tourette's. HDC, histidine decarboxylase gene. This gene is responsible for producing histamine, which is a neurotransmitter. A mutation in the HDC has been linked to a rare familial form of Tourette's. Next is CNTNAP2 gene, contactin associated protein like 2 gene. This is associated with the brain connectivity and language development. Variants in this gene may increase the risk of Tourette's and related disorders. Next are neurobiological factors, which are caused by abnormalities in the basal ganglia and frontal cortex. Imbalance in the dopamine and serotonin neurotransmitters causes Tourette's syndrome. Environmental factors such as prenatal complications like maternal stress, smoking in pregnancy, birth complications like low birth weight and premature delivery, or exposure to environmental toxins or infections in early life causes Tourette's syndrome. Autoimmune factors also cause Tourette's syndrome. Psychosocial factors like stress, anxiety, and excitement, which might be ADHD related, also act as a contributing factor. How is Tourette's syndrome exactly caused? Let's see how those etiological factors affect the brain. The neuroscience of Tourette's syndrome is still poorly understood, but a number of studies suggest an important role of a group of structures known as the basal ganglia. These include the caudate, putamen, globulus pallidus, substantia nigra, and subthalamic nucleus in the brainstem. The basal ganglia are involved in diverse brain functions, but they are especially relevant to Tourette's syndrome for their hypothesized role in suppressing unwanted actions. According to this perspective, One function of basal ganglia circuitry is to inhibit neurons in the thalamus and prevent them from sending undesired movement related signals to the motor cortex. In Tourette's syndrome, it is thought that faulty inhibitory mechanisms in the basal ganglia may fail to stop unwanted signals from reaching the motor cortex. This causes the execution of an action that the patient might prefer to suppress, but it forms the basis for the tics. The failed inhibition in the basal ganglia is thought to be coupled with increased activity in motor pathways, which generate movements. Thus, patient with Tourette's might experience a problematic combination of high motor activity that generates habitual patterns of behavior, along with abnormally low inhibitory activity that would normally keep those behaviors from being acted out. This means that the lack of inhibition is what causing the abnormal tics. Let's see what else happens because of lack of this inhibition. That is, what are the signs and symptoms of the Tourette's syndrome? Majorly, it is two types of tics as discussed earlier, motor tics and vocal or phonic tics. Eye blinking, head jerking, shoulder shrugging, facial grimacing, arm or leg movements, throat clearing, sniffing or coughing. These are vocal tics. Now, here is a graph of body area versus the density of premonitory urges of vocal tics by percentage. Here we can see that body parts such as leg, hand, foot, eye, pelvis, ear, and arm are relatively very less prone to get urges of vocal tics. However, this increases in shoulder, back, neck, back of head, chin, abdomen, cheek, nose, forehead. These are all the moderate amount of urge causing in the tics. Highly, the urge of causing a tic is seen in chest, throat, and the most amount of urge is seen in the mouth, which is why vocal tics are more prevalent. In Tourette's syndrome, tics are just the tip of the iceberg. Motor tics and vocal tics are all we know about from the outside, but on the inside, the patient is suffering from OCD, ADHD, anxiety, sleep issues, rage, behavioral issues, all of these because of the defect in the basal ganglia. Let's see the other common features of the tics. Tics worsen with stress, excitement, or fatigue. Tics often change over time in type, location, and severity. These may occur in bursts. Associated conditions like ADHD, OCD, and learning difficulties, even anxiety and depression can worsen the tics. Now let's see what the risk factors are to look out for in Tourette's syndrome. The risk factors of Tourette syndrome include genetics. If it runs in families, there is a more tendency to have it inherited in the patient. Brain chemistry, imbalance in dopamine and other neurotransmitters as we have seen before. Age. Most common onset is between ages 5 and 10, which means that children in between these age groups are more prone. This doesn't mean that it doesn't occur in adults, but it is more common in patients who are 18 and below to get Tourette syndrome, which progressively comes with them in their adulthood. Gender. It is more common in males than females. Now, this is because of genetic sensitivity. Males may be more affected by Tourette's related genes. Female protective effect, which suggests that females may need more genetic risk to develop symptoms. Hormonal factors such as testosterone may influence brain development in ways that increase tic severity, which is more prevalent in men as we know. Brain structure and connectivity suggest that males and females show difference in basal ganglia and cortical circuits. These areas are key in development of motor and vocal tics as seen before. Higher symptom visibility is often seen in males. Prenatal issues like maternal stress, smoking, or birth complications, as we've seen earlier, are also one of the risk factors. Related disorders, often seen with ADHD or OCD, that means if a person has ADHD and OCD which is diagnosed in the early ages, the patient might be more prone to getting Tourette syndrome. Infections, it has a rare link with strep PANDAS. This is nothing but streptococcal infection, which is pediatric autoimmune neuropsychiatric disorders associated with streptococcal infections. After a child gets a streptococcal, which is like throat infection, their immune system starts attacking not just the bacteria but their own brain cells, particularly in the basal ganglia. This autoimmune reaction can lead to sudden onset of symptoms like tics, OCD, severe anxiety, irritability or emotional outburst, and regressions in behavior or school performance, which is all a contributing factor for Tourette's syndrome. And now let's see, how is Tourette's syndrome identified and diagnosed? The main parameter which is assessed to diagnose someone with Tourette's syndrome is tics. The criteria is that the patient should have multiple motor tics and at least one vocal, which is phonic tic, and it necessarily does not have to occur at the same time. The tics should have occurred many times a day, nearly every day if possible, or intermittently for more than 1 year, which is only when a person will be diagnosed with Tourette's. The other criteria are there should be no tick-free period longer than 3 consecutive months, which means that between two episodes of tics, there should not be a gap of more than 3 months. The tics must start before the age of 18, which is why we see that Tourette syndrome is more prevalent in kids and teenagers. The symptoms should not be due to another medical condition like Huntington's disease or post-viral encephalitis or substance uses such as cocaine and stimulants. We know that Tourette's is mostly symptom-based and observations are always helpful. Tourette syndrome has many associated disorders like attention deficit hyperactivity disorder, OCD, mood disorders, executive dysfunctioning, learning disabilities, which are often seen during childhood. Now, additional evaluation steps include clinical interview, such as interviewing the child, the parents, or the caregivers, observation of tics over time, which is why the 1 year period was mentioned, familial history. Tourette syndrome often runs in families, as we know that genetic predisposition is there. Rule out other conditions such as ADHD, OCD, autism spectrum disorder, seizure disorders, allergies, or throat infections. After we rule out all of these, we are diagnosing them with Tourette syndrome. If a person has ADHD or OCD, he is more likely to get Tourette syndrome as well. Tests. There are no specific tests for Tourette syndrome. However, doctors may use tests to rule out other conditions. These include neurological exam, EEG or MRI if atypical features are present, psychiatric assessment, especially if ADHD and OCD is suspected. After we've diagnosed someone with Tourette's, the next question arises that how is Tourette's syndrome treated? First and foremost, non-pharmacological first-line options. These are recommended before the medications if the tics are mild. First is CBIT, which is Comprehensive Behavioral Intervention for Tics. Most effective non-drug treatment combines habit reversal training and relaxation. This requires a trained therapist. Second one would be psychoeducation plus support. It involves the patient, family, and school, and all of these people are educated about the topic and how exactly one should cope up with it. In conditions where tics are severe, pharmacological treatment is advised. The first line of treatment would be to use antipsychotic drugs. These are dopamine receptor blockers. The drugs are aripiprazole, pimozide, risperidone, and haloperidol. Aripiprazole has fewer side effects and seen often as the first choice. The next are having some side effects such as QT elongation, weight gain, and sedation risks. Next drugs are alpha-2 adrenergic agonists. These are better if tics and ADHD are both present. The drugs are clonidine and guanfacine. Side effects include sedation and hypotension. However, guanfacine is less sedating than clonidine. Next are benzodiazepines. Clonazepam is used and its side effects are that it causes tolerance and dependency. Other medications include topiramate, tetrabenazine, botulinum toxin A. Topiramate is an alternative option. Tetrabenazine is for refractory tics. Botulinum toxin A is for focal, motor, or vocal tics. In some patients, there are more prevalence of vocal tics which appear almost immediately one after the another. In that cases, botulinum toxin A is used. Special considerations must be done for children and lowest doses must be used first. Consider behavior therapy even before that. Adolescents and adults, most tolerance is seen in adults, and higher doses are acceptable. However, precaution must still be taken. Comorbid conditions such as if presence of ADHD and OCD or both is present, then stimulants must be avoided. Alpha agonists or atomoxetine is mostly used. And this brings us to the next question, that what is it like for a person to live with Tourette's syndrome? Living with Tourette's comes with the presence of tics, which can often be looked down upon. We have seen motor, vocal, complex, simple, all sorts of tics. Tourette syndrome also comes with panic disorder, memory deficits, learning disabilities, obsessive compulsive disorder, as we've discussed earlier, mood disorders, executive dysfunctioning, and dysfunction in sensory integrations. These all contribute to major amount of complications occurring in day-to-day life activities. Patients are unable to perform simple tasks without having tics. Living with Tourette's can be challenging, especially due to misunderstandings from others. People, patients may face bullying, social anxiety, and embarrassment, particularly during school years. But with support, most individuals can lead full successful lives. The urge and the relief. Many people with Tourette syndrome describe a premonitory urge, and it's like a tension or an itch building up inside them, and the tic provides relief. The tics, when held, are very uncomfortable, so they have to be acted upon. It is not upon the person to act or not act. The brain just sends signals and the body acts it out without the person having any control over it, which is why those are involuntary tics. Trying to suppress tics can be exhausting and uncomfortable. Patients described it as it's like holding in a sneeze. You can, but it's uncomfortable and eventually it just comes out. It's involuntary, out of control. Tourette's also has a social and emotional impact on the person suffering from it. Embarrassment or anxiety, especially in public and school. People with Tourette syndrome might feel very self conscious or misunderstood because people think that they're misbehaving, when in reality they have no control over their body because of this syndrome. People experience bullying and teasing, especially in school. Isolation. Some people, out of all of this burden, they try to hide their condition and isolate themselves, which can lead to loneliness. Co-occurring conditions. Tourette's often comes with other conditions. We know this: ADHD, OCD, anxiety, or depression. The patient suffering from Tourette's is not only physically exhausted, but even their mental state is not in the most perfect shape. They have to take care of their physical well being and their mental well being. Not only is Tourette's physically exhausting and involuntary with all the tics, it is also taking a mental toll upon them because of all these comorbid conditions. These can sometimes be more disruptive than the tics themselves and may require treatment on their own. So, for a patient with Tourette syndrome, their mental health is at more risk and it needs careful guidance to guide a person through Tourette syndrome for them to live an easier life. However, in the real world, it's not entirely possible. Patients with Tourette's are often highly misunderstood and often judged for behaviors that they cannot control. It leads to stigma, isolation, and unnecessary shame. Now, let's see what the common myths and misconceptions about Tourette syndrome are. There are many stigmas, myths, and misconceptions related to Tourette's syndrome. People just assume that everyone with Tourette's swears uncontrollably. Tourette's is just a behavioral problem. People with Tourette's are always ticking. It only affects children. Adulthood is completely normal. This is entirely false. Some people even think that people with Tourette's syndrome can always control or stop their tics if they try. Such a baseless assumption, right? Tourette's syndrome makes people dangerous or violent, some say, whereas other people say that people with Tourette's syndrome are less intelligent. But all of these are entirely just baseless assumptions. People also think that Tourette's is extremely rare, whereas it is not. In reality, it is about 1 in 100 school age children. It is more common than most people think. It's just that the symptoms are not seen immediately. Tourette syndrome does not affect any intelligence. People with Tourette syndrome are highly talented and smart, as just regular students. Tourette syndrome does not make people violent, it is a very harmful and a false stereotype. Tics can be temporarily suppressed, but it causes discomfort and it even causes rebound, which means that the tics can come off even more intensely. Many people see improvement with age as they set into adulthood, but majority of them continue to have tics still. Tourette syndrome is not just a behavioral problem, it is a neurological disorder. And about the swearing part, only 10% people have coprolalia. Most tics are harmless. They're blinking or even just simple throat clearing, shoulder shrugging, and such behaviors are also seen, but mostly it's just head jerking. So, how can we support someone who has Tourette syndrome? Some supportive behaviors from our side to the Tourette syndrome patient should be that one must be understanding of the patient. We should educate ourselves about the Tourette syndrome. One must never point out their tics because it can be embarrassing and the person may feel inconvenient. We must let them talk about it. If they want to vent about it, we have to let them because it is causing an emotional burden on them. We must be patient with them because of their tic outbursts. They may delay doing some job. So one must be very patient. We must reduce stressful environments because stress is a contributing factor to tics. We must never make jokes about it and never even support that. One must advocate for them in case any sort of bullying is seen. We must focus on who they are, not just their tics. A person is more than just their condition. Now, let's see some famous people who also have Tourette syndrome. First and foremost, we have Billie Eilish, who is a singer and a songwriter. Next, we have Dan Aykroyd, who is an actor, comedian, and screenwriter, and the co-creator of the show Ghostbusters. Next, we have Jim Eisenreich, who is a former Major League Baseball player. Samuel J. Comroe is the next person who is a stand-up comedian and a performer. Despite their conditions, severe tics, and complications, these people were able to establish a successful career for themselves. A person's condition is not a limiting factor for achieving their dreams. These are all the links of the references that I have gathered information from in the making of this video. This brings us to the end of the discussion and thank you for watching.